everyone. Welcome to PSEG True Diversity Film Series, our social justice program. My name is Donna Walker-Kuhn. I'm Senior Advisor of Community Engagement at New Jersey Performing Arts Center. Tonight, our topic is Healing the Divide, Race, Medicine, and the COVID-19 Vaccine. We are pleased to have an illustrious panel of medical professionals who will share their perspectives on this critical topic. This is probably the most important issue in our society at this time, and this panel will examine the history of racial discrimination in healthcare and how the shadow of medical apartheid impacts the distribution of the vaccine. NJPAC's Social Justice Series is part of our Standing in Solidarity initiative. The purpose of this series is to bring our community together and to encourage everyone to take part in the movement to ensure civil rights for all. And since June, we have presented a series of events which you can find on our website and look at all of the various events that we have developed. We also want to acknowledge our corporate sponsor for this social justice film series, PSEG. And very happy to have as our advisors the Newark NAACP, the New Jersey Institute for Social Justice, Newark Arts, and the Truth Racial Healing and Transformation Center at Rutgers University. We also recognize the value and importance of acknowledging the land in which we are located. So we are gathered on the unceded land of the Lenape peoples. We were put upon this turtle island not to seek dominion, but as caretakers, and we gather here in a good way to be with the earth's children in all of their forms, those of the land, the water, and the air. We, the Lenape, original benefactors of land once ripened and cultivated with attentiveness to the Creator and her ascendancy, express everlasting gratitude to our Creator for the traditional ancestral jurisdictions of the Munsee, Esopus, Canarsie, Capsee, Werpos, Sawano, and Wekaswek, jointly known today as the Rampopo and Nakako Lenni Lenape. We are the Lenape Hoking today and will be for the remaining days of tomorrow, keepers of the past. Let this moment of recognition be a monument of action. Let it be the beginning of hope for this, our Turtle Island, and for the Rampopo Lenape, the Munsee people of whose land we now trod. Here on this land, in this place of the Munsee, we acknowledge our debt to those who have come before us, to those who've been denigrated and suffered for the sake of cultural and land appropriation. Let this, our land acknowledgement, be the beginning of our return to unity. Let us be guardians of the water, the air, and the earth, the four-legged, the flyers, the swimmers, the crawlers, the mammal people, and the green. Let us now stand lifting our humanity, enrapturing with Earth's consciousness as guardians of harmony and kindness. We offer a pledge of social justice, awakening, and education in order to raise the level of awareness and to ultimately strengthen the communal fabric, which includes outreach with our Indigenous neighbors. In this way, our collective voices can disrupt the patterns of social injustice through reverence of the Native people who share their land and by revitalizing Indigenous history through Indigenous-specific programming. This statement was prepared for us by the Rampopo, New Jersey Chief, Dwayne Perry. So now I would love to, and I'm very excited to present a video message from our Mayor of Newark, Ras Baraka. He's going to comment on the theme of the panel this evening. Let's take a look.
Hello, this is Mayor Ras J. Baraka, and just want to thank and congratulate New Jersey Performing Arts Center for their continuous efforts to raise awareness and use the arts community as an opportunity to not just talk about issues that pertain to Newark, but kind of national social justice issues. And this one in particular is incredibly important around health and the racial divide, particularly around COVID-19 and the coronavirus and this vaccine and everything that is associated with our community, and all of the inequity that has been unearthed because of this virus has really made it very front and center And so we either have two choices: to allow it to continue to ravage and disturb and destroy our communities, or begin to address it head on. I want to thank the esteemed panel that they've gathered together to talk about this issue. Thank all of you for thinking it not robbery to be on and engaging and listening as this goes, because this is very, very, very important as we try to march against the COVID-19 and get people to take vaccines that we believe will protect them, our communities. Listen, black and brown people are maybe 2 or 3 times more likely to die from coronavirus than anybody else, and it seems to almost like 10 times less likely to take the vaccine. And that is because of deep-rooted history of not just racism and ill treatment and systemic violence in this country against black and brown people, but specifically because of the relationships that exist presently between our healthcare industry and our community. The lack of access, the poor treatment, the poor care, the lack of wellness, and the lack of primary care physicians or black and brown faces in the medical field, whether they be doctors or surgeons or epidemiologists or any of these people, even healthcare workers, in our community, credible messengers. And I think the health industry needs to take a real good look at itself and begin to make some serious changes, not just because we're trying to get people to vaccinate themselves, but because we need to create opportunities where there's good health in our community. And one of the reasons that we cannot fight the COVID-19 as well in our neighborhoods, in our city, is because we have all of these other conditions that come from the kind of environmental racism that exists here, the lack of access to good food, to quality care. All of these things are very, very, very important, and I'm glad we're beginning to have discussions about it. So again, shout out to NJPAC, John Schreiber, everybody who helped put this together, all of the panelists that are here together, that are courageous enough to discuss these issues, and more importantly, to do something about them. So Godspeed to you, and have an incredible event. Thank you.
Thank you, Mayor. It is now my pleasure to introduce our moderator for this panel, Dr. Denise Anderson. Dr. Anderson is founder and CEO of Denise Anderson and Associates, an independent public health and healthcare consultancy business. She's also the executive director of the New Jersey Department of Health's Maternal Care Quality Collaborative and principal of the COVID Rapid Mobile Response Team at the New Jersey Department of Health. Welcome, Dr. Anderson.
Good evening, and thank you, Donna. I'll just add to that wonderful introduction that the lens that I speak with the audience tonight is through the lens of a Black female scholar activist. And so I am going to one by one bring our panelists on so that they too can briefly introduce themselves and let the audience know the lens by which they are speaking tonight. The first person that I am going to call on is Dr. Davis. Unmute.
Thank you, everyone. Thank you for allowing me this opportunity, this marvelous opportunity to participate in this dialogue with such a remarkable group of concerned and remarkable colleagues. I'm just delighted. So I am really excited about talking about the syndemic that is COVID, in addition to the health crises that we face in our community as African Americans. My name is Iris L. Davis, and I'm a physician who's trained in internal medicine, integrative and functional medicine, as well as medical acupuncture. So that kind of gives you a little idea that I might work a little differently. But I've worked with multiple populations over the 40 years that I've been in medicine, and 25 of those years were dedicated to those in the HIV and AIDS syndemic or synergistic epidemic, because all epidemics are not the same in all populations. It may be the same agent, but it is not the same disorder necessarily in how it is perceived, how it is treated, and how people can access care. So that's my view, helping you to understand the issues of what I call structural racism and a healthcare system that is really based on a class-based care structure that allows a limited population to have access to all of the remarkable things that we do have in both our standard allopathic system and also in integrative and natural medicines. So it all depends on who you are and how much deep money there is in your pockets. So, but as a community-based provider who's an African-American, a woman, and a survivor of multiple autoimmune disorders, I'm deeply aware of those discrepancies in our system and the dissemination of medical information and how difficult it can be when you're trying to look through all those prisms. But I do still believe that we can use these opportunities for growth and use these difficulties for change so we can develop and grow in new paradigms and paths. Thank you.
Thank you, Dr. Davis. Next panelist to bring on for introduction is Dr. Elna Hall.
Good evening, everyone, and thank you, Dr. Anderson, for the introduction, and to my co-panelists today, and of course to the mayor for his leadership of the great city that we serve at a university hospital. I am so privileged to be the president and CEO of University Hospital and to serve this community. And as we think about the theme of this panel, this isn't just a panel about vaccines, about a disease. This is a panel where we're going to be discussing inequities that have plagued this community for generations, not just since the beginning of this pandemic, which has really surfaced and made all of these inequities so visible to everyone, especially those who live and work in this community. I will tell you my experience walking through the halls in mid-April of 2020, when I saw over 300 patients in our hospital, when I was walking around with boxes of PPE with my co-leadership team, trying to support the frontline heroes that we had, who are also overwhelmingly Black and brown people. You couldn't help but notice, of course, that almost every person in our patient rooms was a person of color, and out of proportion, frankly, to what we normally see. And we proudly serve a majority minority community here, but it was clear to me from the beginning that we were dealing with something that was devastating to this community. And when we talk about vaccines, when we talk about treatments, when we talk about the medical establishment and its history with people of color, but also the way the medical establishment treats people of color now with implicit bias and with everything in between, we have to be talking about inequities front and center in this discussion. And I'm so appreciative to NJPAC for framing it this way. And I look forward to the panel. Thank you very much.
Thank you, Dr. Elna Hall. And now we will bring on our third and final panelist, Dr. Halkitis.
Good evening, everyone. I'm very happy to be here with you. My name is Perry Halkitis. Where do I start? I'm a cisgender, gay man, child of Greek immigrants who was born in Queens, New York, and is now gladly and proudly a resident of Newark, New Jersey. I come to this work as someone who has been doing infectious disease epidemiology and activism hand in hand over the course of his career. First, with regard to the HIV epidemic, but certainly not in the last year solely about the HIV epidemic. I have been working, as my colleague Dr. Davis has, at the intersection of looking at how structural, behavioral, biological, psychosocial determinants drive health disparities in all populations. And with the notion that one size doesn't fit all. What vaccine hesitancy means in one population is not what vaccine hesitancy means in another population. How we message to people about how they stay safe in one population is not how we message to people in another population. And I think what we have to do together, and that is the medical profession, public health, the community, and industry, and this is why I'm so happy NJPAC is doing this, is collectively think through how we modernize the delivery of healthcare to equally serve all people and populations. I'm tired about hearing about health disparities. I'm tired of it. It's time to shift the conversation from health disparities to health equity. We know there are differences. We know brown and Black people suffer at abominable rates, not just from COVID-19, but myriad other diseases. And these things just don't happen for no reason at all, right? People don't wake up one morning and decide they want COVID, or decide one morning they're going to acquire HIV, or they're going to have an opioid addiction. Life gets people to this place. And so we must challenge the inequities, the lack of access, the discrimination on every front that people continue to face in their lives. And only then I think, do we have a chance at equalizing the playing field and creating equal health for all people in our society. So I'm very happy to be part of this conversation and to join my esteemed colleagues in helping uplift the issues that we've all been struggling with, not just for the last year, but quite frankly, in this country for the last 402 years. Thanks.
Thank you. All right. And so I'm going to start us off with a slide set that really looks at the foundation of health disparities. All right, next slide, please. So I'm going to briefly discuss the evolution of the field of medicine, right? In parallel to the experience of African Americans and Blacks in the US, because as already mentioned, the disparities that we see today, they have been interwoven into the fabric of this country. So during the pre-industrial era, the field of medicine was pretty unsophisticated. Individuals decided to practice medicine, and physicians and then others shadowed and practiced them as apprentices. Also, the field of nursing was pretty unsophisticated. At this time, there was no insurance of any kind, and eventually a small number of medical schools were established. But for the most part, the delivery of healthcare was as follows. You had almshouses for the poor, elderly, homeless, orphaned, sick, and disabled. There were asylums, which were inpatient psychiatric facilities for the mentally ill. Pest houses were used to isolate people with infectious diseases. And there were dispensaries that were free outpatient clinics that provided medical services to people who could not afford to pay. In parallel, during this pre-industrial era, Africans were entrapped and transported to the US. Next slide, please. So during the post-industrial era, there was the development of cities and what we call urbanization. Additionally, there was the advancement of science and technology to the field of medicine. The medical field became professionalized and legitimate, one could say. The American Medical Association, or AMA, emerged initially to control medical schools, and they worked with states to establish medical license laws. And then eventually they turned to galvanizing and advocating and protecting the interests of physicians. Medical education became affiliated with universities. There were science courses added to the curriculum, and an undergraduate degree with entrance examination became a requirement for medical school admission. Nurses also became professionalized during the post-industrial era. And then next, the demand for health services necessitated the centralization of medical services in facilities located within cities versus making house calls or doing home visits. Next slide, please. For African Americans during the post-industrial era, Jim Crow and Black codes relegated racial and ethnic minorities to second-class citizenship after emancipation and to substandard health and education. Then there was the infamous 1896 Plessy versus Ferguson decision that legalized segregation under a separate but equal provision, with the but equal clause really never fulfilled. This decision reduced Blacks to the receipt of substandard health care. So, to address separate but equal, churches began to develop separate facilities for Blacks. Since medical schools at the time would not admit Blacks, medical schools for Black doctors were also created. Of course, the separate health facilities and the medical schools were not as well funded as their segregated counterparts. When Blacks did interact with the segregated white medical system, there were inequalities in medical treatment. These inequalities led to racial and ethnic disparities in accessing the healthcare services, as well as choosing to go and receive healthcare services due to the differential treatment. And then there was also deceptive treatment of Blacks. And I think the Tuskegee syphilis study is one of the more widely known examples. So this study was led by the United States Public Health Service. Syphilis treatment was intentionally withheld from poor Black men for 40 years, causing pain and suffering, not only just for the men, but their families and for the greater community. However, it's important to note that we don't have to go back to the Tuskegee syphilis study that began in 1932 for examples of negligence, abuse, disrespect, and not being heard in healthcare. We watched Dr. Susan Moore's recording describing disbelief of her pain and not being heard by her medical director or provider while she was hospitalized and before she died from COVID-19 related complications just this past December. Next slide, please. So the social determinants of health are the conditions in the environment where we're born, where we live, where we go to school, where we go to work, where our children play, where we worship, and where we grow old. That really affects a wide range of health, capability, risk, and our quality of life. And this phrase, social determinants of health, is fairly recent. And every time I talk about health disparities, I can't help but to go back to W.E.B. Du Bois' book, The Philadelphia Negro, which was published in 1899. He spoke about the exact same social context that we are talking about today. He spoke about differential social advancement and conditions by which Black and whites lived. Today, we can describe that with the differences between urban versus suburban. So it is indeed the differential treatment of African Americans since slavery and the separate and unequal treatment in all aspects of life, including healthcare since slavery, for which the legacy of racism really matters in present day health. The COVID-19 pandemic has exacerbated the issues experienced by Blacks for over 400 years. It is just as important to note that health disparities exist for other races and ethnicities and other demographics that my colleagues on the panel will chime in on shortly. Next slide, please. So allow me to just briefly describe what we now call the social determinants of health that were described by W.E.B. Du Bois in 1899. We have economic stability, talking about things like employment, debt, financial support, and gender pay disparity. We have the neighborhood and built environment. Blacks remain the most residentially hyper-segregated population in the US due to both institutional and individual racism. The inability to get bank loans in certain areas, that's institutional racism. And real estate agents that refuse to show homes and owners that refuse to sell homes in certain areas to Blacks, that's individual racism. In addition to housing, there are concerns around environmental hazards such as lead and crime and safety. In health and healthcare, we have health coverage or insurance or lack thereof. We have the availability of a provider where you need to access care. Then we have things like cultural sensitivity and the languages spoken by providers, and also the quality of care that we receive. In the social and community context, we're talking about things like inclusion and active participation in society. Active participation such as voting. It's hard to be included with the disproportionate number of Blacks that are mass incarcerated. And it's actually hard to actively participate in society when your neighborhood may be dilapidated and unsafe, when you're unemployed or you're underemployed, so you're working, but your wages aren't enough to make your ends meet, when you're harassed and killed by police, and when you regularly face aggressions while being Black and participating in everyday activities such as sitting in Starbucks coffee shop while Black, shopping while Black, driving while Black, exercising while Black, bird watching while Black, and sleeping in your home while Black. At last, education, the tracking of our children, remedial education, underfunding, understaffing, and poor curriculums. And it is all of this that provides the foundation for health disparities. Before asking my colleagues to chime in on the foundations of health disparities, one of my favorite quotes by James Baldwin really sums it all up. To be a Negro in this country and to be relatively conscious is to be in a rage almost all the time. My colleagues and I on this panel acknowledge that. And so I will open it up at this point in time for any of the panelists to chime in on any components of the foundations of, health disparities as just described.
Well, I would like to comment on how much I enjoyed your presentation. And I think that what is important is that people often look at us as providers or people who have knowledge within the medical field, but not realizing, although I think that Dr. Halkitis and all of us have touched upon it, all of us also ran into that same issue. They teach about race in medical school, but they never talk about the racism, including the racism that's right in front of your face, or how they address a patient, or how they won't treat this patient, but they'll treat the same patient over here that happens to be Euro-American and has the same medical problem. But there is no change in the percentage of African-American professionals. African-American women in medicine are 2.2%, and they've been so for about 25 years. So I think that when you realize this, that it's not just a structural issue only at the level of the community, it is tethered and totally enshrined in all aspects of American life. To develop the America that you're describing, where healthcare is equal to all, has been a multi-community, multi-racial, multi-group initiative since I went to medical school, and that I knew of. And I knew people that fought for it before that, and I'm sure that Dr. Halkitis and Dr. Einal can also say the same thing. So I think there has to be a recognition that we all have this opportunity to keep trying to create change as we walk through our daily lives as providers. But also that the community also has that opportunity to reach out and to recognize, because like there were over 200 Black hospitals, but once there was the institution of Medicaid, almost all those Black hospitals died, So there's a long and lengthy backstory. The question is, how do we go forward?
Absolutely. Thank you, Dr. Davis.
If we have the time, Dr. Anderson, I'm happy to chime in. Just Dr. Davis' excellent comments. I'll frame this in as real terms as I can. Some people in my field, the medical field, the medical establishment, hospital presidents believe that, look, you have government institutions, you have government agencies that should really take on the mantle of social determinants, that it's not really our business as hospitals and clinics to worry about that. That's not our role. I don't have the luxury of feeling that way. And the reason is ground zero for folks in communities like Newark tends to be in two places. Number one, the criminal justice system. And number two, our emergency room. That's where the lives end up when society has failed people. And I can't tell you how many times I've seen report outs every morning where we have homeless folks come in with pneumonia, for example, in the dead of winter. We treat them for that pneumonia. Their breathing is fine, their oxygen is fine. This was before COVID, by the way, let alone the effects of COVID. And then what do? We discharge them right back on to the streets so they can get pneumonia again. We can't do that anymore. We have to take ownership and be stewards of people's lives and finally solve problems. And everything you outlined, Dr. Anderson, I view that as our collective responsibility in the medical establishment to finally do something about it, to start putting cracks in the institutional racism that has defined our institutions, including here in Newark, for too long. Thank you.
Thank you, Dr. Elnahal.
And I'm just going to briefly add just very brief comment to my amazing colleagues' comments, which is to say, there's this chasm, there's this space that unfortunately exists between medical care and public health. And that's a bad space because public health folks are very, very concerned, as we are, as all of you are, with the social determinants of disease, with social justice issues, with discrimination, with racism. And I am not convinced always that the medical profession has the same ownership. So the way we solve this is not by pushing each other apart more, but by bringing our efforts together. If we mend the chasm that exists between the social justice, social deterministic, very, very deep-rooted perspective of public health, and I will just say that, I am very proud to say that modern schools of public health like ours at Rutgers are rooted in social justice and health equity. Maybe in 1972, they were about epi. Now they're about social justice and health equity. If we do that and marry our efforts with the medical profession, we will solve the problems that we face in our society.
Absolutely. Thank you, Dr. Halkitis. And so I am going to ask you, Dr. Halkitis, to lead us into the next segment. Just what is COVID? What makes this a pandemic? What really puts people at risk? What do we look like as a country in the state of New Jersey over a year later? And what do we do in order to, mitigate the spread and get this under control?
So thank you for that. So if we put up my slides, I have some very basic slides here relating to COVID and its manifestation as a biological agent. But I want to start first and foremost by making two statements. The COVID-19 pandemic is not just a viral phenomenon. It is a social phenomenon. It is a political phenomenon. It is a behavioral phenomenon. It is a psychosocial phenomenon. And if we think that vaccines alone and treatment alone are going to solve it, we are out of our minds, right? And this is as true for COVID-19 as it is for HIV. I will say that in the 1980s, when I was coming of age as a young man in New York City, I was part of a population that was forgotten by politicians. That was the gay population. And the president just ignored us. Last year, I think what we saw in our country was a president who purposely lied to us and as a result of that, lives were lost. And so I don't see public health and politics as being separate, and never can they be separate, because if there was any lesson we've learned last year, it was that one. So next slide, please. We know all of this. These are just the basic elements here. The disease of COVID-19 caused by a virus, just like HIV is caused by AIDS. This is the name we know it by, but it is more than just a virus, right? It is more, the COVID doesn't just fall from the sky into people's lives, right? COVID is acquired because of circumstances that people are facing. Next slide, please. And what we know is that over the course of the last year, we've seen a variety of different manifestations of this disease. And what I've been saying in the press consistently and, tagging on often to my wonderful colleague, Dr. Lahal, is that we're learning something new every day, right? And so, yes, maybe we were a little too late to the mask game. Yes, maybe we were a little too worried about the bags from the supermarket, but every day is new information. And so I hope we enter this conversation about vaccine knowing that every day is new information about the vaccine too. Right now, the evidence suggests that, and Dr. Lahal, I'm sure we'll be talking about this, that the vaccine is effective for 6 months' time, but we don't know much more than that at this point. And so we have to, as a people, be willing to accommodate new information as it comes along. Next slide, please. Over the course of the last 100 or so years, we saw a drop in infectious diseases throughout the world. But then, all of a sudden, over the last 40 years, there's been a spike. I imagine that what we're going to see as we continue to be a global society in which we travel all over the place, in which we trade all over the place, is that COVID-19, the SARS-CoV-2 virus, is just the latest in a series of viruses that are going to affect us. So what this means to me from a political perspective, and why I say COVID-19 is a political phenomenon, is that politicians, governments around the world must commit to protecting each other. And that only happens if we collectively agree to be open and honest with our science and open and honest with the public health that is taking place in our countries. Next slide, please. And so at the beginning of the epidemic, all we had were behavioral approaches. We targeted people, we tested them, we treated them, and we did tracing. And that's what kept us going for a while. And we did that somewhat well, not perfectly, because human beings are difficult to work with. And human beings are complex creatures. And getting them on the phone and getting them to trust a contact tracer is a big, big step. And rightfully so, because we were living in a society, and we continue to live in a society where people are cast aside, where people are kicked out of the country, where children are locked in cages. So people have a right to be afraid. And that's what made our challenges over the last year so incredibly difficult when it came with regard to contact tracing, because people were just afraid. They were afraid that government was going to come and take control of their lives. And as much as we tried, we didn't really overcome that hill. I also think we have another problem we have to face as a country, and this is just my politics around education. We need to do a much better job teaching science to our children. Because quite frankly, unless we do that, we're going to have a new population in 20 years' time that's not going to understand how viruses work, or bacteria work, or vaccines work. And knowledge is power. Next slide, please. In addition to that, we know very clearly that the other way we fight this disease is through mitigation strategies. So more, as important as ever, wearing a face mask, keeping 3 to 6 feet. Now we know we have new recommendations from the CDC, washing hands and getting vaccinated. I will tell you, my friends, given the data that I have seen over the course of the last year with regard to the flu and the lack of flu in our country during the last season, I will be wearing a mask in the fall and winter of 2021, 2022, because that seems to me like a layer of protection in addition to my vaccination that I'm willing to take for my own benefit, but also for the benefit of people around me. To this point of benefit and altruism, I've talked a lot in my work also in the last year about the idea of empathy. And I think what we need to think about collectively also is how do we take care of our fellow citizens? And so when I would describe my own behaviors as, I would wear my mask, I would wash my hands, I would do everything possible to mitigate the disease, the spread of the disease. I would say, I think about my brother, who was 3 years younger than me and was living with MS. And the last thing I wanted was for him to get the disease from somebody who was irresponsible. So that was my commitment to him. And I asked every human being, and I've asked every human being over the course of the last year to think about the person they love the most and enact these behaviors because of them. Next slide, please. We have a variety of different ways to do our testing. We know we have to trust these tests. I leave these here for you. We have done a study of antibodies in Essex County, which is just being published right now. And lo and behold, you will not be surprised to find that brown and black people who did not know they were sick had been exposed. That brown and black people who had been working on the front lines had been exposed and they weren't aware. And so these kinds of studies become crucially important in characterizing this epidemic and all the epidemics that we're facing. Because like many diseases, including HIV, viruses, pathogens do not discriminate based on socioeconomic level, but eventually they do discriminate, and they lodge themselves often on the lower end of the SES, which is too often occupied by brown and black people. And so understanding the spread of the disease, understanding the dynamics of the spread is going to be another crucial step as we prepare for managing this virus and future viruses. Next slide, please. And contact tracing, and I'll leave it at that. Next slide, please. This is where we are today. This is, a look at the Johns Hopkins map that shows in very bright, beautiful orangey red, all the parts of the world that are being adversely affected. And you can see very clearly that the United States is a hotspot. Western Europe is a hotspot. South America is a hotspot. And over the last few weeks, we have seen an increase in infection. Why do we see that? Well, yeah, we have more contagious strains or variants. I accept that. But what we've really seen is people's behaviors becoming lax. The idea that the vaccine is a panacea, and all of a sudden the mask goes away, the hand washing goes away, we're gathering, everybody's getting together, and the disease is spreading. And I worry what's going to happen over the next couple of weeks, given what we've just celebrated Passover and Easter. And we didn't even celebrate Orthodox Easter yet. That's next month. So we have another doozy ahead of us. Next slide, please. Okay, so now I'm going to leave you with this because I think this tells a story. Here's Brazil, Canada, and the United States, not shown to size. It shows you the population, the number of cases in each of those countries, and the deaths in each of those countries. And that looks okay, right? Well, the United States is bigger, so of course it has more cases. But next slide, next slide, please. When we control for the population of the country, what do we see? On the left-hand side with the red bars, The United States far exceeds the world in terms of cases. 9,155 cases per 100,000 people. In the world, it's 1,670. Even in Brazil, which has a horrible reaction, a horrible response, it's 1,673. But in Canada, it's only 2,671. And I often put the country of Greece there because of my ethnic pride, one, but also because here is a country that for the last 15 years has been in economic turmoil, yet somehow they've managed to contain the disease. The same pattern exists when we look at deaths. Globally, 36 deaths per 100,000. The United States has 166. You cannot tell me that place doesn't matter. You cannot tell me that politics do not matter. These charts show that very, very clearly. Next slide, please. And so what the future holds, we have to continue to stop thinking that the vaccine is going to solve our problems. Continuing to engage with our mitigation strategies, seeing how the vaccine, and Dr. Allen will talk about this, are we going to need boosters? Are we going to need an annual shot? I predict we will. We have to think about the slow and methodical reopening through the end of 2021. Do I think by Christmas, Hanukkah, Kwanzaa of 2021, potentially we have a more quote unquote normal perception, reality of the world? Maybe, but the old normal wasn't so great anyway. So let's think about a new normal that's even better. We also have to think about the effects of long haulers and what this disease is going to mean to people's bodies. Establishing new norms. I have no problem moving forward, going to a concert or to a baseball game, to a football game, and having my temperature taken. Why not? 50, 60 years ago, people would go to the airport. There was no scanning in the airport. We do it now. People just get used to it. We need to think about strategies there. And then, of course, increase funding for public health and prevention, because what we saw in our country was a country that had depleted support for public health. And as a result, we were left empty. Next slide, please. These and other ideas, you can follow me on Twitter or all those other places. Thank you very much, Dr. Anderson, and thank you, colleagues.
Thank you, Dr. Halkitis. Dr. Elnahal, Dr. Davis, would you have anything to add? No? Okay. All right, very good. So, Dr. Elnahal, we're going to take it over to you. And some of the things that come to mind is, exactly, what is medical research? And what is that golden standard of a double-blind clinical trial? What do we mean by representation in clinical trials, and why does representation matter? And the other things that come to mind are, what protections exist for people today? What are some of those principles that came out of the Belmont report that spoke about respect for persons and, moral obligation and justice?
Thank you, Dr. Anderson. And I think, Dr. Halkitis, your setup here with the basics of COVID and how it has impacted our communities was so helpful. It just gives me the platform to talk about how research intersects with this issue and with our communities. I want to talk about history just very briefly. And the reason I want to be brief is that for a lot of folks, the history matters a little less than what they're experiencing right now. But I do think the history is important to set the stage. And really, when it comes to experimentation and research for Black people in particular, that started hundreds of years ago. And it started when Black persons in this country were enslaved. The most illustrative example, and there are many more, was a gynecologist by the name of Dr. Marion Sims, who cared for white people in an ethical manner at the time when he was a surgeon, but learned how to operate and learned how to do new experiments by experimenting on enslaved women. And I talk about that because I've attended, I should say, workshops with Black doulas, Black women in particular, talk about how slavery still exists in the psyche of Black women today, to a point where, for example, a common thing that's clinically noticed is that when you complement a Black mother for how cute her child is, regardless of gender. A common reaction is to sort of deny that. And to do so is almost sort of reflexively. And the way this was explained to me by a Black doula who was talking to me about breastfeeding when I was health commissioner in the state was that that's actually a generational reaction that is learned from the fear that enslaved women used to have when they had attractive children, for fear that they would be taken away from them. And so that anecdote, and of course it doesn't ring true for every woman, but that anecdote meant so much to me because she hears it from people that she trains in breastfeeding every single day. And when you talk about what it must have been like to be treated as basically a guinea pig on a surgical table when there wasn't anesthesia, for something as sensitive and as sacred as, a GYN procedure, the anatomy of a woman's body that was violated at that time. These are narratives that still, to some extent, ring true today, invariably so. But that has to be thought about in terms of the origins of skepticism around experimentation. And of course, there's the Tuskegee Experiment, which is well known, has been discussed ad nauseum, where you had Black men who had served this country in uniform, lied to by the federal government, were told they were going to get free healthcare, weren't even told they were going to be in a study, let alone told that they were living with an illness that was eminently treatable. But because the establishment needed to learn about the disease and what it could do to people, they let these Black men live with a disease called syphilis that can be very severe if left untreated over time. And so while this isn't necessarily in the forefront of people's minds, it does inform, I think, a lot of the way folks think, especially in Black and brown communities, about research and medical experimentation. I'll proceed to the experience today, and there is proven epidemiologic research on this, whereby clinicians of all colors simply do not take these symptoms as seriously and respond in the same way when a Black person is in front of them. And it's a little bit worse for Black women, according to the research, but still nonetheless there for every Black person who presents in a healthcare setting. This is what I think predominates the skepticism around, be it physicians, be it, authority figures, who may be the most credentialed, experienced, well-intentioned people in the world, who say, we generated this shot in less than a year, please take it. So we have to come to these discussions with humility and understanding. And I've been doing a lot of listening in this community for the last, since we've been talking about vaccination, but even before that in this pandemic, as we've been engaging virtually with as many people as possible. And really what ultimately comes out is that, even if we convince folks that the research behind these vaccines is legitimate and is up to the standard that we all hope, and I do hope to be able to convince as many folks of that as possible during this call and this meeting, we cannot ignore the public health issues that have plagued communities like Newark for a long time. And Dr. Davis mentioned this briefly in her introduction, and I'm sure she's going to talk in more detail about it. But we're talking about, diseases and conditions. Dr. Halkitis mentioned HIV, AIDS. Why don't we have a vaccine for that yet? Why don't we have an effective way to, screen enough Black women for breast cancer to detect them early instead of late? We see too many unnecessary late-stage diagnoses of cancer, whether it's colon and rectal cancer, exceedingly high rates in Black men, cervical, breast cancer in Black women, chronic disease that plagues everybody in the Black community. These are issues that need to be solved, and they can be solved, and the COVID vaccine effort was proof of that. If you have will, if you have money, public money going into this, going right to pharmaceutical companies, by the way, and we'll talk about that. If you have, mobilization in all gears of policy to make it easier to treat this disease and ultimately develop a vaccine and therapeutics, you can solve public health problems. And don't think that's lost on the communities that we've been talking to. They said, okay, fine, you've had this discussion with us, we buy it, but we don't buy the fact that our public health issues have been ignored for generations. And that's something we have to make sure we do with the best of our science and the best of our technology as a society going forward. And I think the intentions and the promises and the initial efforts by the Biden administration have been impressive on this. But that has to get to the finish line because people want execution. They want screening in the community. They want people screened for basic issues like hypertension. That is what's going to save more lives than any vaccine, whether COVID or not. And I think that's a backdrop that I really want to emphasize. But let's talk about the evidence and let's talk about some of the myths behind COVID-19 vaccines. A lot of folks say, hey, the quickest other vaccine that was developed for this was for smallpox, and that was developed within a matter of just a few years. This is less than 1 year. And so why was this able to be developed so fast? Why are you telling me it's safe when that's the best other example that we have? Few reasons. Number one, we actually had a lot of lab research and basic science that went into the technologies for the Moderna, Pfizer, and the Johnson & Johnson, the most recent vaccine that led up to this. So a lot of folks say, hey, this mRNA technology, this adenovirus vector technology, or any technology behind these vaccines, how did you fashion this so quickly? I'm suspicious of that. The truth is there have been really decades of research that have already gone into this, and COVID was the most recent challenge on which we could apply that very long period of extensive, at least basic science research. But if you develop something like the mRNA vaccines, you still have to see if it works in human beings. We have to be humble when it comes to biology in the human body and understand that even if we have the best thought and the best preliminary evidence that say something works, you don't know if something works until you actually do a clinical trial. So Dr. Anderson's cue for me to describe that is really important. The only way you can really say that a vaccine is effective or a drug or a therapeutic is if you actually randomize people either getting the real thing or getting what's called a placebo. A placebo is a decoy where you basically, have something like salt water that ultimately looks and feels like the real thing. The study participant doesn't know, and if it's done right, the actual person injecting it in the case of the vaccine doesn't know. And the idea is you ultimately compare infection rates between someone who got the real vaccine and someone who got the decoy or the placebo. Over time, you see how many people in both arms ultimately got infected, but very importantly, you also see what the side effects and adverse events are in both of those arms. And so when folks hear, for example, that, hey, people who got this vaccine got Bell's palsy, well, when you're doing a study with tens of thousands of people in it, hundreds of thousands in some cases, you're ultimately going to get folks developing conditions. And so the question is that condition statistically more common in the arm of people who got the real vaccine versus the placebo arm? And the reality is, for a lot of these scary things that have been talked about in the press, that have been talked about on social media, there really isn't a difference between rates of folks who got the real vaccine versus placebo. Ideally, you should be doing these trials over a long period of time. But when you have a lot of people enrolled in a trial, you can detect statistical differences in both side effects and effectiveness much faster. So when we say something is effective and safe, we have almost a year's worth of data to be able to say that. Do we know for sure that 5 years from now, folks won't develop an adverse event that we weren't aware of when it comes to these vaccines? I can't tell you the answer to that as yet because I don't know. We don't know what the long-term effects are. What I will say is that extensive research of vaccines in the past have really found that severe adverse events over a very long period of time are rare. There have been discussions, for example, about the prevalence of autism and whether that's related to vaccines. The person who originally published a study on this out of the UK actually was found to have falsified data. And so that study ended up being retracted from the British Medical Journal, and that person was essentially banned from, publishing studies and going forward because of that research. But because of that, there's some sense that, hey, vaccines can be dangerous in the long term. We don't know about this new technology. Again, I will be the first to say that. But with the legacy and the history of vaccines we know of up to this point, the long-term effects of vaccines have not been, in general, have not been found to be high risk. So that's what I'll just sort of caveat overall. What about the particular vaccines? Well, it turns out that the mRNA technology seems to be extremely effective at developing vaccines and developing immunity. So for Moderna and Pfizer, you have 95% effectiveness. That is rates that we've never seen before for vaccines. Yes, you have side effects, but there's a difference between side effects, which last for just a few days, and maybe uncomfortable, like fever, muscle ache, what have you, fatigue, but they go away, they're self-limited, and importantly, it is a much better and safer experience than getting COVID-19 itself. So when we compare the idea of getting a vaccine versus, or the decision to get a vaccine has to be compared with the alternative, what you're trying to prevent, which is COVID-19 itself. And so for that reason, especially those first two vaccines with 95% effectiveness, but also the Johnson & Johnson vaccine, which overall has a little bit lower effectiveness, but has a 100% effectiveness at preventing hospitalization and death per the data we understand now. So in other words, all three vaccines that are available are extremely effective, have very little risk of severe adverse events. In fact, the only thing is a severe allergic reaction, which is treatable immediately. Everybody is observed in that 15-minute period to make sure they don't get that. But ultimately, no other real severe adverse events have been noticed at all with these vaccines in these clinical trials. You mentioned the safeguards, and I'll mention this briefly before ending here. The way that these companies have to do this research in the US is that they actually have to have something called a data safety monitoring board that is completely independent from the company. In fact, the way this works is that after a certain period of time, the data that this company has is blinded to its executives and it's submitted to the data safety monitoring board, which then tells the company's executives whether the vaccine worked or not. There are very important and clear safeguards to manipulation and doctoring of the data. And it's the data safety monitoring board that reports the results back to the company. You may have seen a little bit of a snafu with AstraZeneca, because what happened was the independent monitoring board submitted the data back. Within less than 24 hours, they put out this press release. And then the data safety monitoring said, wait a minute, no, you're not, we gave you that raw data, but here's our analysis. It's different from yours. Retract it. So the company actually had to take it back in a very embarrassing way. And part of the reason why we don't have AstraZeneca available yet. Probably a very effective vaccine. The FDA has to do its own research. But ultimately, I do trust that there are safeguards in place for really understanding whether a vaccine works. And I think I've gone over time, but I'm happy to answer any other questions about this. Thank you very much.
Thank you, Dr. Elder Hall. Very briefly, Dr. Davis, Dr. Halkitis, would you add anything to what Dr. Elder Hall had to say?
I always love hearing my colleague, Dr. Elder Hall, and his comments. And I to the HIV point, which is, very near and dear to my heart, which I've been doing for over 2.5 decades. I think, what we see here, which is the theme of, our panel tonight, is that in the 1980s, we had a population that nobody really cared about, right? Who cares? Gay men are sick. IDU are sick. Who cares? They're like the other people. And now, even to this day, now that we have gay men who are mostly Black becoming infected with HIV, it's all but absent. Our ability. Yes, we have PrEP. Yes, we have undetectable equals untransmittable. That's all good. But this effort for a vaccine doesn't really seem to be like on speed drive for most pharmaceutical companies.
Dr. Davis?
I have to say, as someone who practiced in Baltimore for over 20 years, I thought of the HeLa cells, which Hopkins also used to do some of the vaccine research. And that family still has never been reimbursed, and they still live in poverty. And so as a person who knows of the family and lives in a community small enough so that the family's seen and heard often in media, it's striking to think of the millions. And I think of the academic centers, all academic centers. I'm not talking about yours, Dr. I've never worked in Newark. But I think of all academic centers which primarily sit in communities of color and how little they have done to change the health statistics of the communities that surround them. They do hire a lot of people, you know, but when you talk about the cleaning crews in this country, you know, I think it's as high as almost 30% are really people of color. And, you know, and if it's African-American, it was 13%, which we only come up with about 12%. But I just thought of all the other structural issues that were not specifically related to your, but I do think it has a great deal to do with why the vaccine issues are not being heard. Because there's all this underlying resentment.
Mm-hmm. Mm-hmm.
Which you discussed very actively when you discussed the father of gynecology in the United States, whose statue was just taken down in the last year. You know, so I think that as we have this continual look back and look forward, we have to say to people, you have to look at the fact that in so many states, I mean, you know, when you're talking about Illinois, the vast majority of people that died were African American. When you're talking about Louisiana, it was primarily New Orleans African Americans. If you're talking about Mississippi, there's only a few states where Blacks don't provide a higher percentage of the deaths. And I think that that's a very crucial area that we hopefully can discuss in terms of vaccination, making people understand that if you live in an area of prevalence, which is what Dr. Perry Halkitis and I are really saying, if you live in an area of prevalence, where prevalence is high, how much disease is in your community that you don't know, that's why he found all those antibodies, then that makes your issue of look and see if the vaccine is the right thing for you so important. And I thought you really gave a very graded and, you know, consistent perspective to help people understand that. Thank you.
Yes, absolutely. So this is the perfect segue for you, Dr. Davis. I'm going to ask Danielle to pull up your slide set, but you know, we hear a lot about equality and equity, and there's a difference, right? And so what is the difference between equality and equity, and which one do we prefer? And, you know, I talked in the beginning about the inequities that existed prior to COVID. And so how do we move forward in just this
We had
opportunity?
equity before COVID?
We did.
Where?
So how do we
I live in America. Where do you live?
Dr. Davis?
Okay, I just wanted to make sure we're in the same country. So let me start out by saying that the benefit of being a provider who was trained in one of the last public health hospitals in New York before they closed it down, they've only down to about just a few now, was really understanding the key concept that we could not be separated from the community that surrounded us, which was Central Harlem, 96th Street. And if they came across the bridge, it was the South Bronx. It was a remarkable education for a young woman who came from the suburbs of Washington, D.C. So how can we? Well, so let's talk about equality. I apologize for the noise in the background. And let's see. So you can see that my slides start with equity, equality, and now what's highlighted, Dr. Anderson? Justice. Yes, ma'am. Because they may sound similar, but the implementation of one versus the other can lead to dramatically different outcomes for marginalized people of any group or for folks who are discriminated against for any reason, okay? And that's crucial to understand in healthcare if we're going to discuss the populations that live in Newark that are predominantly affected by this issue of the COVID syndemic. I know that many of you are saying, why does she keep saying syndemic? Because it's a synergistic epidemic that you cannot separate from the social issues and the environment that the epidemic develops in. So African Americans have always died of preventable and treatable disorders to a greater extent than Euro Americans, including in 2020. And as well as do Latino and Native and indigenous populations as well. So whether we are discussing the deaths of mothers giving birth, cancer, diabetes, obesity, medical racism, or environmentally caused illnesses, lead, poison water, poison air, toxins, African-American health statistics already describe a community that was under significant health stress. And the majority of healthcare, let's just talk about nursing homes. Now, I want you to think about, in terms of COVID, I want everyone in this audience at this time to think of what would have happened if PPE had been given to the majority of the home health care aides in the nursing homes of America. Who are those women and who do they look like? They don't get sick leave. They don't get paid leave. And they don't get enough PPE, as do many of the hospitals that serve underserved areas. So I just want to make that one correlation, which is why some people want what Dr. Anahal was discussing, which is the vaccine to protect themselves, but other people are like, well, they didn't care about us then. And I think that continuing issue of equity, equality, and justice therefore becomes quite clear. So I think reviewing those structural issues that causes pathways and hurdles to healthcare in America becomes a predominant issue, since there are now multiple studies documenting Blacks don't get it because we're fatter. Blacks don't get it because we're just poorer. We don't get it because we have more hypertension. We don't get it. We get it because of where we live, how much we earn, and the jobs we have. Let's get clear. There are now 4 major studies that have documented that. So if you don't have a system in place to take care of the people who are becoming sick because of a particular agent, and there's not adequate structure to take care of those people, you say, when you go home, you don't need an ICU bed right now, and I don't have a single spot left, like has happened in Queens, and hopefully has not happened in Newark to the same degree. But you're hearing that discrepancy. Why aren't we using the other hospitals? Why aren't we sending those people across town? So these are the kind of subtle, if it is subtle in any way, issues that we need to discuss as we discuss health equity, equality, and justice. So that key issue, though, we're not more susceptible. There's a higher prevalence in the communities that we live in on a larger level. So in all the studies that were done in New York City, Michigan, the Veterans Administration, more African Americans were infected than Euro Americans. So I want to be clear. So now let's go to the next slide and let's get to Dr. Anderson's questions. Well, first of all, does everybody like the apple tree? Everybody come on under the apple tree now. Now, which side of the apple tree do you like? Notice that there's a few more apples on that side over there. And the young person over here is like, well, would that one of those 2 apples please fall down? And inequality is unequal access to opportunities. I thought we should start with what is inequality. Now, if we go to the next slide, equity. Equity says, when you've only got 2 apples on the one side, I might need a larger ladder because I have to reach one of only 2 apples. But still, all the apples, there's so many, they kind of float on out of the cartoon, are on the other side. So tools are customized, if you're talking about equity, to address the inequality, to improve the recognition of different circumstances. For example, there's affirmative action in colleges. But have they designed a program that would make sure that people that came from those communities that were not always previously accepted in that college environment succeed and do well? So there's equity, but now let's go to equality. Next slide. So equality means that you're evenly distributing tools and assistance. So now everybody's got the same size ladder, but since the tree leans a little to the left, the child on the left is really having no problem, and it has more apples anyway. The child on that left is having no other. So if you have a person or a group of people that already have more apples on their side, and you're telling, but you're equal, you've got the same opportunity I did, but I don't have the same tree you did. So then you have to talk about, are you evenly distributing tools and the assistance? I thought we would make this dialogue very basic. So then how do you go to the next slide? And on the next slide, we're talking about justice. So first of all, we had to move the trio. We had to turn the ladders. We had to structure some of the other branches. And we had to put everybody on the same side. Do you notice the difference now in justice? Justice is a place where you fix the system to offer equal access to both tools and opportunities that are appropriate for the affected populations. I'm not aware of justice in the American healthcare system at this time. I didn't find a lot of justice when I was on the tuberculosis wards at Harlem Hospital and all our patients were dying because they all had HIV. It was a concurrent synergistic epidemic. These kind of synergistic epidemics, like if I went right now from here to certain areas where the opiate epidemics are occurring, which are actually often more Euro-American, but are different pockets of class. They're as well not having access to certain structures and causes. So by August of 2020, COVID was the third leading cause of death in African Americans. But if you don't measure African Americans and you don't think that race or class and where someone works and where someone lives are important things, you cannot tease these issues out. That's as much a part, how you measure your data is as much a part of health equity as the treatment you give. You can't put treatment where it's needed if you don't have the data to say, we need more. I don't know if University Hospital receives as much as I think they may need to be supported versus an institution that's in the Rutgers area. If I'm going to discuss New Jersey, since I don't know the state. But what I'm trying to say is that in every part of America, rural hospitals have been allowed to die. So that when it finally got to rural America, people had to travel hundreds of miles to get to a physician or to get to an ICU, or they had to be sent out by plane. We destroyed the public healthcare system of this country in many ways in the past 30 to 50 years. And so now what we have is an infrastructure where there's not adequate care and service at points of need. When someone said, why is COVID the third leading cause of death in African Americans, and they decided to send payments to certain hospitals, why did the private hospitals with less cases get more money than the cases with the most, than the hospitals with the most cases in this country? Because of the way that medicine is structured. Medicine is structured on the same economic base as much of America. And so I talk about this issue because I think that, you know, I'd like to find your apples under your apple tree. And I'd like everyone to have access to the apples. So this equitable solution, however, if we're not going to allocate those resources that each person needs to access to the fruit, then we're not going to develop positive outcomes for both individuals. So the tree looks like it's a naturally occurring system. It's critical to remember that social systems aren't naturally inequitable. We forget that a lot of medical anthropology in this country was started to prove the necessity for slavery. Measuring skull size, et cetera, things of that sort was all done to prove that other groups were not as good as Euro-Americans. People forget that the Nazis studied the United States before they developed the ovens. It's crucial to recognize who we are, how we got there, how we have been able to change the situation in some instances, and not use that as an excuse not to look at the options that I think Dr. Halkitis and Dr. Einahal have given us here tonight, so that we can begin to say, how will I take action? What brings justice to me? So then we can begin to look at the structural issues and the way that we can all begin to change excess deaths in any community. So I would love to hear from my colleagues, because of course I could keep going. You know, I'll ask Dr. Einahal and Dr. Halkitis and Dr. Anderson, what would you like to add to this dialogue on equity in health and healthcare structures and systems?
You want to go, Sharif?
I'm happy to. This was such an illustrative look at this problem, and it is so interwoven in everything we face as a safety net hospital. So, for example, we are starting to see a wave of people with mental and behavioral health issues coming into our emergency room, being admitted onto our psychiatric unit, and we're bursting at the seams on top of an increasing caseload of COVID-19. And of course, you can guess the demographics of the folks coming in with these problems, the toxic stress that people of color live with in our community. Now, guess what the comparative reimbursement rates are for mental health issues that people come into hospitals with versus something like, a cardiac surgery for an elderly woman or an elderly man that may be just more commonly done in suburbs. Much, much, much lower. The systemic racism as inequity is literally baked in to the Medicare and Medicaid rules that govern how we are paid, reimbursed, and resourced. And so when you talk about PPE, we had a state that recognized we were an area of need. So we got enough PPE, thankfully. But that couldn't have been the case necessarily if somebody else was in office. But that's just one micro example. There's just so much structural inequity built into the system that we have an old infrastructure that needs to be replaced that's over 50 years old. We have, a general, paucity of resources to serve the basic needs of the community. And no one's going to tell me that the mental and behavioral health issues that people live with in this community are less serious than this or that, maybe dermatology issue that is, reimbursed much more and resourced much better based on the way our system works. So really just baked into everything we do in healthcare. And so it's not just what can we do more locally, but how can we change policy to better reflect that example that Dr. Davis gave us of the child that needs to be on a higher ladder, closer to the apples, and something that brings the tree over to give more apples to the one who doesn't have as much access to it. There's so many examples of that we live with every day at University Hospital.
Mm-hmm. Thank you.
Just very, very quickly, to these excellent points my colleagues made. And, I live in that amazing space of the syndemic, along with Dr. Davis, the syndemic, sin from the Greek word, of course, the Greek word, meaning together, epidemics, right? So where you see one health problem, you see other health problems. Where you see drug abuse, you see cigarette smoking. Where you see cigarette smoking, you see COVID. Where you see COVID, you see HIV. These things don't exist like in isolation, right? And they synergize each other and they make each other worse. And so, and as Dr. Davis very beautifully said, it's the psychosocial conditions that fuel these. I also want to say just two more quick things. I think we've got to get to the point where when we're talking about health, mental health is health. Just like skin health is health, and and sexual health is health. It's just health, right? Because the bottom line is we know that mental health issues are due in large part to neurotransmitters being out of whack, right? So there's a biological basis as if that would make people happy. There's a social basis there, and then last but not least, the social justice issues, the lack of justice, has to be corrected in the healthcare system. It also needs to be corrected in the academy, because the academy is fraught with structural racism. It's fraught with a funding body of the NIH that funds Black scholars at much lower rates than white scholars, that funds men at much higher rates than women, that funds topics on Black populations at much lower rates than other topics. This is not acceptable. That system's broken. And what has to happen is people like me, who've had the privilege as a white man of all the benefits society has given me, to stand up and say, I've had this privilege because of the color of my skin, and this is not okay. And this is not okay. And we cannot expect the burden for these changes in the healthcare system and in the academy to fall on the shoulders of our, brown and Black brothers and sisters. It's not okay. And so I ask everyone out there who is an ally and an advocate to join me in fighting for these changes on every single level. We need leaders in schools of public health and in schools of medicine. that look like the population. We need people working in public health and people in our classrooms that look like the population. Because quite frankly, my friends, right now, it's not the case. And that's the only way we're going to affect the change in this country, ultimately.
Well said. Dr.
I don't
Davis.
think about the issue of gender, because there are many more single mothers among African American and populations of color. We can't
Absolutely.
leave out the issues of gender, and we can't leave out the other issues that you mentioned, and the fact that that as well impacts, and who those people are within the work order is crucial to understanding that. But I do think when I see like the comments on the side that say, how can we impact, how can we help people to get the vaccine? It's by recognizing who people are and respecting and honoring them. So I want to thank each of the panelists and our moderator for giving us an opportunity to offer that kind of setting tonight.
Dr. Davis, your presentation was phenomenal. Thank you for that. And so I'm going to ask each panelist if you want to give in 2 minutes or less, any last remarks before we open the discussion up to our audience for Q&A. I'll start with Dr. Elnahal.
I will just say that that was exactly the right presentation to end on, Dr. Davis, because it really underlies the root of almost everything I said, and Dr. Halkitis as well, about this disease and what it's done to our community and the issue of vaccination overall. The one thing I'll just end with, just briefly, is that the data, the science, we've been talking about science a lot, is actually not showing that Black and brown people are the most hesitant to take this vaccine. It is actually folks of Caucasian background, but in particular, folks who have a conservative ideology or identify as Republican. I want to make sure that that's clear. That is where the most significant hesitancy right now is coming from. Black and brown people were never absolutely hesitant to take this vaccine. They wanted to learn more. They wanted to have the conversation. They want to go through the journey because we don't have the right to immediately demand trust from people in this community for all the reasons we've talked about. But there's never been rates of absolute hesitancy or denial, anti-vax sentiment, if you will, in Black and brown communities nearly at the rate of other communities. And that's being borne out by the data now. And so the question we really have to evolve to is, of course, there are still folks who are hesitant going through that journey. We have to work with those folks as much as possible. But now it's a matter of equity to actually give access to people who think the vaccine is right for them and want to take the vaccine in Black and brown communities. And that is a matter of equity that I think so far has not been met. We're talking about still less than 10%, way less than 10% actually, of the city of Newark fully vaccinated. Compare that to approaching 20% of New Jersey and a little over 20% for the entire country for the general population who are fully vaccinated. Inexcusable. If we are spending all of our time trying to get folks through that journey, and at the end of it, after we've had that conversation and folks are there, we say, actually, you can't get the vaccine yet because we don't have supply and it's not near you and it's not accessible to you and you need broadband and you may not have it, whatever it is, then we're still failing. And so we have to close that loop and actually deliver not only the vaccine, but really everything else that we are telling our community they need from a healthcare standpoint.
Thank you, Dr. Elnahal. Dr. Davis, your closing.
Okay. So I actually thought of it in just as what you said. I think first and foremost, if we can't find a way, we can't be like Memphis, where they said on a Friday, if you don't, everybody who can use the internet to get in, and they did that in one of the poorest pockets and one of the most densely African-American parts of the city. So there were no slots left for any vaccinations for anyone in that community by Monday, because it was based on the broadband and the internet. There has to be some type of allocation that has to happen at a system level. And not only does it have to have a system level, there should be vaccination workers and workers that are in communication with the community. And you need to stop thinking of Walgreens and CVS. You can also give vaccinations in churches, in community centers and community health centers. You can give them in those schools where they're empty because the kids aren't there. It's called a gym. You can start being creative because we're good at being creative in these communities. I think that the reality of not wishing to be creative is because people are stuck in their behaviors. It's not because they say, I don't want any Black people to do it. They say, I don't want to go to the extra effort and find new pathways to give. So on that basis, that's the first thing I have to say. So I think that we have to develop a paradigm where we increase that capacity, as Dr. Alhan said, and as Dr. Helka, as all of us have said. Now, on the individual level, I would like to remind everyone that's listening to this entire, what we're trying to offer here tonight, to remember that your health, first of all, begins with you. It's not just about COVID and the vaccination, and I know that, I understand that, but your immune system, your humoral system, your stress system, all of those things also contribute to how you handle any disorder. If you have another disorder that's out of control because you're not taking care of it because of COVID, you need to go and take care of yourself. I want you to have the joy of self-love, okay? And once you've taken care of that joy of self-love called self-care, I want you to recognize that already you are a survivor because you're here in 2021. And as you do all those things, open yourself to what can you do to make yourself the healthiest being that you can be, and disseminate that information while you're standing in line for the vaccine, okay? That would be excellent. On the group level, tell your family to do the same for themselves. Organize to bring your network. I'm speaking to all those sororities, all those faculty groups, all those known groups and unknown groups, whether you're seen and or unseen. I want you to take action to make sure that people come into your community to access. You have more power than you know. And one of the greatest things I learned in all the years of organizing in HIV was getting people to stand up outside of their group and organize and say, we want a center here, if it's only one day a week. You have to have that kind of opportunity and that kind of growth. So I speak from that background because that's how I function. Lastly, I have to say, as a community, America is a community made up of communities. And we are a diverse country, and we have the capability to create safety, health, and capacity in each one of our communities. A lot of that, the primary issue with care is really part of the structural gap that's causing the racial issues in coronavirus deaths. So those key issues of structural conditions, are something that we can begin to continue to change. Remember that, 18% of all healthcare workers in this country are African-American. Cleaning people, 13%. Public transport, 1 out of 4. Warehouse and postal service, 1 out of 5. We are the front line. We are the essential workers. We are. So I think that we have to understand who people are so that we can respond to their needs. And if we can respond to their needs and bring vaccines to them in a way where they can access them on their time, which you can't do when you're working 2 10-hour shifts as a home health care aide, I desperately ask for community-based mobilization. And I desperately hope that we have all encouraged you to recognize your incredible power to create that.
Thank you, Dr. Davis. Dr. Halkitis.
I'll end with 3 words and 3 ideas: empathy and altruism, resilience and creativity. And I think these are 3 very, very important constructs as we confront this pandemic and as we think about future pandemics. Number 1, we have plenty of literature out there to support that when we care about our fellow human beings, their health improves. We know this from the HIV literature. We know it from the other literature. I spent way too much time on Sunday talking to my 75-year-old aunt, Katerina, who wanted to go to the casino, because that's what I need to do, to convince her not to go to the casino because her life wasn't depending on going to the casino, right? And so that love for her, for my one remaining aunt, was what drove me to spend all that time on the text. I want us to do the same thing for the people we love in our world. So that's number 1, empathy. Number 2, public health models have been built for the last 100 years on deficit, what people do wrong. Oh, they don't wear a condom. Oh, they don't take their vaccine. Oh, they're hesitant. Oh, they smoke too much. You know what? Most people do things really well. and they're resilient, and they have grit, and they have fortitude. And I want us to shift the paradigm to start developing public health programs that are based on strength and resilience and fortitude and what people are doing right? So for like every one person that's not getting the vaccine, there's probably 5 who are. What are they doing that we can learn from them and build models up from them? Last but not least, creativity. You know, it's the same thing I was saying before about the NIH. That model is just broken. We need a new way of thinking about the NIH and how it funds research projects. We need to be creative in how we deliver our care. My very, 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 very dear friend, Dimitri Daskalakis, who is now at the CDC, who is now the head of the HIV bureau there, you know, because, you know, we are all Greeks, all know each other, and we talk to each other. We're just like one big happy family. When nobody would go to the bathhouses in New York City to do HIV and STI testing, you know what? He did. And that's how he found people's infections, and that's how he treated STIs. And that's the kind of out of the box thinking. I want tents outside in front of the bodegas doing vaccinations. I want, when the schools are open and we only have approval, that sugar cube that I got with the polio vaccine in the 1960s. I want the equivalent of that in schools to get our kids vaccinated. So it means thinking in non-traditional ways, because the traditional ways are not serving us particularly well.
Thank you, Dr. Halkitis. And so my closing remarks before we go into question and answers is to, you know, encourage everyone to do your research for yourself. In making your decisions, make sure that your decisions are informed decisions. And honestly speaking, that, you know, the only source of information cannot be from social media. I acknowledge, as others, that so many aspects of the vaccine has been and continues to be unprecedented. It can be concerning and uncomfortable. I had to weigh my pros and cons before deciding to get vaccinated, and everyone must do the same. Do you have underlying conditions? Does your occupation or where you live make you more susceptible to infection? And perhaps you answer all of those questions and you feel that you're good, but you are around a loved one that meets the criteria I just spoke of. So should you get vaccinated to protect them if you can't think about taking it for yourself? Talk to a trusted medical professional about your concerns. And if you don't have a trusted medical professional, then we have to start using consumerism to find one. We need more discernment in who we allow the privilege of taking care of our health. Now, I recognize that choices that we have in the US, absent a universal health care, is controlled by having insurance or not having insurance and what's covered by the insurance company. So I'm advocating that we optimize controlled choice. Let's think about the time that we put into researching the purchase of goods such as a television or our cell phones or a laptop. We need to use what is out there to help us in making decisions about who we select to provide our healthcare services. We can look at things like Yelp and health grades and Google reviews. We should have expectations about what good delivery of healthcare should look like, and we shouldn't settle for less. I need a physician that has non-traditional days and hours of the week. If you're only open Monday through Friday from 9 to 5, I can't use your services because that's when I work too. You know, appointment availability. If I call tomorrow and you tell me that you can't see me until August, that's no good for me. I'm looking for folks that have things like, you know, upgrades, patient portals. I want to have access to my information. I need for a staff to pick up the phone when I call, and I need for them not to be rude. And I need a provider that's going to call me back within a respectable amount of time. Whatever it is that's important to you and your family, don't settle. What's the saying? Believe what a person shows you the first time. So believe when the provider does not meet your needs the first time. Do your research and make a change then, because it's so much harder to change providers when in the midst of a health crisis. So when your care has been unsatisfactory in your normal interactions, don't trust them to be different during a crisis. There's a study by Brown and colleagues, and what resonated with me about this particular study is that it talked about the power of consumerism in healthcare and patient experience, so that the health system will transform when patients as consumers of healthcare services use their experience to actually select who provides their care. when the employers and the health insurances actually use your experience to design payment systems, and when the medical staff and the administrators act on your experience to actually improve the healthcare practice systems and care that you receive. Vaccine side effects, let me just acknowledge that it is difficult to feel fine and then take a medication with potential side effects that could make you feel sick. But as already stipulated, just keep in mind that side effects from the vaccine are less severe than possibly being infected with COVID and experiencing severe complications that could lead to hospitalization or even death. And lastly, racism must be addressed in all aspects of society, including healthcare. We have to address it within institutions through assessment and revision of policies, and at the individual level through ongoing training and skills building of healthcare personnel, and the identification and personal ways to mitigate both overt and covert racism. So I'm going to now look into our question and answer box and see what questions we have for the panel. So one question, I did get the Moderna vaccine. Does it affect our DNA?
I'm happy to start. No, it does not affect your DNA. The way that technology works is that it's a blueprint for your own cell to make a protein that looks like the spike protein. So if you've seen these pictures of COVID-19, in the press and in, pictures and what have you, it has spikes. So what the mRNA does is it goes into your cell, and your cell has machinery, little proteins that make that spike protein. And then it's released out of your cell, and then your immune system works against it so that if you ever face the real COVID, it can wipe it out. Your immune system can wipe it out. At no point does that molecule ever come in contact with your DNA. So it cannot possibly alter your DNA.
Anyone else want to contribute to that? Okay, next question. I am a teacher. Why is it that distancing guidelines changes from 6 feet to 3 feet in the schools? What about the teachers?
Yeah, so look, this gets back to the point. First of all, my husband's a teacher, so I was a teacher early in my career as I was doing my doctorate, probably like the greatest job I ever had in my life. Lin-Manuel Miranda was in my science class in 6th grade. Okay, mark that down, folks. Anyway, so I think the teachers have to be vaccinated, right? I think that they have to be vaccinated. And I know the Governor Murphy's really on board with that. So that's what first and foremost. Number two, I think the more and more we get the vaccine out there and we begin to get closer and closer and closer and closer to herd immunity, then the viremic pool that exists, in our society decreases. So the distance becomes less important than it was before when the viremia was high. So I think that teachers, by the time we get back to school in September, I have suggested that I think we get to a place in New Jersey that is adult herd immunity by the end of July. I think we're there. I hope so. So that by September, the teachers should be in a pretty safe place when the kids come back to school.
Thank you. We have a couple of questions as it relates to booster shots. And so one is, I understand that the data of the vaccinations is new and limited. Is the understanding now that there is an expectation that there is only a 6-month coverage from the vaccines, and there is definitely a need for a booster shot in 6 months?
I'm happy to start on that one, and my co-panelists want to add anything, absolutely feel free. So the short answer is that we still do not yet know how long immunity lasts after any of these vaccines. And we know that they at least last 6 months, likely up to a year based on what we've seen so far. But until we have these studies go on for more than a year, ideally for at least a few years, we won't know how long you'll have antibodies that last after getting the vaccine. And so it could be the case that we need the vaccine every year, sort of like the flu shot, or it could be the case that we need it once every few years or 5 years, or it could be the case that we need it only once in a lifetime. We simply do not know yet.
And I think that there's a
go ahead,
lack
Dr.
of dialogue about the heterogeneity of populations. You know, you can't necessarily teach someone who's going for a transplant, someone who's got autoimmune disease, someone who's got other diseases that may disturb their hormonal and immune systems. You know, some people have great guts, but a lot of people in this country have a terrible microbiome. So you don't know their antibody and their whole pattern. So what you're talking about is really all you can really talk about at this time is we're going to see. And that's really what I think Dr. Elnahal is saying. We're going to have to see if there's change across populations. And that's if they do the studies in an individualized enough manner.
Right.
And if they include enough people of different groups, different communities, and different ages, which at this point, you know, we're still kind of, we're fundamentally working on an adult plan of herd immunity.
Right.
You know, and you know, so one of the points that I didn't get a chance to bring up, because you know we can cover quite a bit. If you look at who's getting sick right now, it's people who are younger. It's not the elderly. And is that the COVID variants? Because we don't have enough genomic tracing in this country, if you ask me. And to be quite honest, Dr. Elnahal, I don't think there's enough tracing of vaccines and vaccine side effects. So those kind of things impact the way people respond and then have a way to cope. Just like we don't know how to deal with the long-term COVID halls. That to me are just like the people I've seen with CS, you know, with chronic fatigue syndrome and Lyme syndrome and all these people that have these chronic issues. So there are ways that there are different aspects of society cope with these things, but all of these issues can't be answered today. I think what we are trying to do today is bring to you the concept of this vaccine is out here, it's effective. You heard the numbers that man spoke with. Both those men spoke with. I didn't do those numbers, not about health any. But I think that it is crucial that you recognize it's one of your tools.
Right.
It's not somebody else's tool, it's your tool. Take your power.
Right. I think that, I love Dr. Davis's comment. And, it was anathema when I said 4 months ago, I think we should start with the 18 to 25-year-olds and vaccinate them first. But I'm not supposed to say that. But, I feel like they're the ones who are out there, like sort of like doing their thing, right? And that's why we're seeing this spread. But I think ultimately, as Dr. Elnahal said, look, we know from Pfizer that 6 months looks for sure. More and more people getting vaccinated means more and more data will come out, and we will just see. Like we didn't know when, Dr. Davis, this when ART first came out in 1996. Who knew that we were going to flip the whole epidemic at that point and make viral suppression a reality? Who knew? But we knew as time passed. So patience, I know, is something we're not good at, but we have to be good at it with this particular disease and any disease if we're going to defeat it.
Mm-hmm. Thank you, panelists. What have the studies shown or thoughts regarding teenage females and fertility?
So yeah, sure, I'll get started. So there is no evidence that any of these vaccines impact fertility. So that's an important thing to clarify, because there is a lot of information, misinformation, in some cases disinformation, which is the intentional move to dissuade from doing something. It's pretty telling, for example, when one of our adversaries, country-wise, is trying to spread vaccine misinformation. Obviously, their intent is not to help us, right? And one of those false narratives of that is that it impacts fertility. There are, historical issues and things that have come up throughout time that make folks skeptical around, for example, the perceived desire for communities of color not to be able to reproduce. And so some of the reasons why these ideas take hold are because of the issues of racism that we've been discussing. But there is no evidence from any of the clinical trials that I've heard everything from sperm count to fertility of women and everything in between, no evidence of that.
Okay. I have two questions that are similar in terms of, I'm sorry, Dr. Davis, go ahead.
I'm so sorry. I think if you're going to talk about issues like fertility and stuff, people are worried about this vaccine, but in the environment we live in right now, fertility has gone down. So there are plenty of other toxins in the environment that are really much more documented to be affecting the sperm count, for example, of men. But there's no information, just as Dr. Ellenhall said, that some of that stuff has to be followed out over a long period of time.
Thank you. We have two questions around, the differences between the three available vaccines and kind of doses. So, the 2-dose vaccine versus the Johnson & Johnson 1-dose. One of our attendees is going to go get the J&J vaccine on Thursday. Want to know, what the differences are and why is it that 2 of them are 2-dose and the Johnson & Johnson is a 1-dose?
I'm going to let Dr. Ellenhall offer the biology, but I want to start this and say, the right vaccine for you to take is the vaccine you got, right? And I know, I think this is true, Dr. Ellenhall, that for people with an autoimmune disorders, it may be that the Janssen vaccine is somewhat more preferable than the 2-dose vaccine. I don't know if that's really true. And that's my understanding from my conversation with my brother and his MS doctor, but all of the vaccines are equally effective in providing protection.
Yeah, I'll just add on by saying we are most concerned, obviously, about 2 bad outcomes that can happen with COVID-19. Hospitalization, your chances are worse if you have to be hospitalized with this disease, not just chances of death, but chances of dealing with something called long hauler syndrome, like Dr. Halkitis, Dr. Davis mentioned. All those things go up if you have to be hospitalized, but of course, death. And so those 2 across the board with all 3 vaccines are 100% effective. As far as we know, and we're talking about tens of thousands, hundreds of thousands of people for some of these trials, 0 people had to be hospitalized, 0 people died if they got any of these vaccines, Johnson & Johnson included. The reason that the first 2 are 2-dose and the third one is only 1-dose is that that's how they were chosen to be studied. So it may be the case that Moderna and Pfizer are good enough with just 1 dose. In fact, there is strong evidence from the CDC based on how these vaccines have been operating in the real world. Again, we only have a few months of data on this, so Dr. Davis's caveats on looking at this in the long term are very important. It may be the case that they're effective enough with 1 dose, but we don't know that for sure yet. And so what the right thing to do is to do what was done in the clinical trials. So for the first 2, they were done with 2 doses because that's the way the company wanted to study it. That's what the science suggested was the right thing to do. And the 1 dose for Johnson & Johnson. So that's what we recommend folks do.
Okay, great.
And Dr. Anderson, if I could just add really quickly, assuming, and this is a big if, and Dr. Ellenhall said this before, we don't know if we're going to need boosters. We don't know if we're going to need monthly shots, yearly shots, but let's imagine we do. You need yearly shots. The vaccines will evolve. The polio vaccine, when it started out, was live polio. It eventually became an inactive, agent, right? It started out as an injection. For kids, it became something on a sugar cube. So with time, the mechanics will improve, and the delivery will improve, and the vaccinations will become, in some ways, more efficient just because the technology will get better.
Thank you for that. And so combining kind of several questions in the queue now around structural reform, how are medical schools changing their curricula to incorporate known areas of bias? And, what is the most supportive thing that white healthcare workers can do to help bridge this divide?
I think I'm the closest to medical school in this group, so I'll just comment, it's not being done enough, okay? A lecture here or there about equity and, disparities in public health outcomes as of, 10 years ago is what I experienced. Now, hopefully they're better now than they were 10 years ago. But my suspicion is that we're still not doing enough in emphasizing and weaving, frankly, equity into everything we learn in medical school. That's really how it should be. Because when you actually get there as an intern, as a resident, or even as a medical student who's first rotating. I mean, it was to the point where I remember rotating in the ICU in the pediatric unit. And my team, look, I'm not disparaging them as individuals, but we were going around to these sick kids in the pediatric ICU. And, it happened to be that in every child who was white was so cute. And then, the Haitian kid came up, or, somebody else came up. I didn't hear that comment. And, me being a brown guy, I'm like, what's going on here? You see it and you notice it and it bothers you. And, unless these things are emphasized, reinforced, to keep reminding people of these issues, they're going to persist. And so the simple answer is not enough. And we need to innovate in our curricula to make sure this is ingrained in everybody who has the privilege of treating a patient after they graduate.
I'm very proud to say that the Rutgers School of Public Health will be implementing a required course for all its students on the history of racism, discrimination, and the health of people and populations. Because we can't just assume students know that. Kind of like we just can't assume that students come to our school, and I say this to my medical friends, and know the difference between a virus and a bacteria. They don't, right? And so we have that course too. So having those courses and making it structured, not just like one lecture, like a real course on this issue, on these issues, is what's needed.
Mm-hmm. Mm-hmm. Thank you for that. Dr. Davis, you look like you were going to say something.
I'm trying to find the button. Okay. So I have to say that as a physician, let me do it as a physician. Now, as an internist, you're a primary care doctor, and you see people with insulin resistance of all types, type 2 diabetes, hypertension, strokes, ASCVD. How many people ever get good dietary information from their physician when it's the primary thing most physicians treat? High blood pressure, diabetes, obesity, stress syndrome. And people say, well, how did you get your degree in functional medicine? I said, because I wasn't going to keep on passing out those pills. It's not that I have a problem with treating someone appropriately for a disease process. If you have reached the level of type 2 diabetes, but how many physicians in a community, especially among African Americans, are checking their insulin levels at fasting and postprandial levels? That's ridiculous in a country where obesity and diabetes is at the levels we have. That's just one point, right? So what I'm trying to really say is, if you talk about the history of racism, the Dr. It wasn't as bad as I'm sure when I went through medical school. However, having been in 5 medical schools, I can assure you that I was known as the mouthy one, because I would politely go around the corner and pull your jacket and say, did you notice the way in which that response occurred? And it makes you an outlier, and it makes you someone with a target on your back, because you're not willing to behave like you're a white male in brown skin in a female body. And that's fundamentally the cultures that all people of color run into in professional cultures. And I don't care if you're a white woman, a Latino woman, an Asian woman, a Hispanic, you're getting the idea. We have to come to understanding and making it normal for people to be the diverse group that we are. It's not acceptable in professional culture still, across the board.
And so you literally just answered one of the questions that was, why aren't enough medical professionals and news outlets reporting the natural benefits of holistic health practices, physical movement, and a healthy diet?
What was my individual suggestion? If you don't love yourself, and that's what we don't do, we don't look at it as self-love. It's self-love. Self-care is self-love. And that position of saying, okay, I have to work 2 jobs, I have to do this, I have to do that. Okay, so can we just do trauma tapping for maybe 3 minutes? Can we focus on, okay, I understand that you're really addicted to those Cheetos. Is it Cheetos or Cheez-Its? One of those things. But if you already are kind of tending, I can't tell you how many people come to me and they say, well, Dr. Davis, I have to find something on the quick. And I said, well, maybe there's spinach, broccoli. I said, and steamed vegetables. You know, there's a lot that you can do, but it is an education process and it's not paid for in the healthcare system. So I know, so see, Dr. Ellenhall started to grin. So I know I'm really starting to go off here. I'm going to try to behave, but it's not paid for in our healthcare system. So if we don't develop a healthcare system that's really oriented to the prevention and treatment of disorders, we are never going to get anywhere. You know, we talk about COVID, but we haven't even discussed environmental pollution in the Black communities. If you're talking about anywhere with an environmental crisis, it is poor communities of color. The traditional communities where Blacks were allowed to settle in various parts of the country, because they didn't just live in the South, they also lived all throughout New England and the mid-Atlantic. You know, those areas were always the swamps, the marshes, the this, the that. They're leaving in climate change. And so what happens to those areas? So the Gullah are going to lose their beaches that they've lived on, but I guess nobody will have them in a while. But the reality is that we're not talking about asthma. We're not talking about, you know, we're not talking about all the different issues and aspects of care that can help you to continue to be healthy. What we're trying to get across is that one key aspect of health is available somewhere in Newark. You two, Dr. Anderson and Dr. Ellenhall, are going to work with the institutions that you have developed, and you're giving people the ability to access this tool if they so choose. They can come to somebody like me for insulin resistance.
Thank you. Dr. Elnahal, I think this next one is for you. I am a Newark resident and University Hospital is my local hospital. What is UMD&J doing to address the health disparities in the city? And do UMD&J hiring practices support the demographics of the city?
Thank you. It's an excellent question and a very fair one, because the Newark agreements, in fact, promised this hospital to the Black community that it displaced, one of the most prosperous Black communities in the country, in the 1960s. And we have fallen short of that commitment for too long. And so I can tell you, excuse my kids who are yelling at me right now, I can tell you that I keep the Newark agreements on my desk to remind me every day why I am there. And it's not going to be easy to change that trajectory, but we're doing a number of things to rededicate to the community. The first thing is that we're making sure that we do have a workforce that is diverse. Hey guys, please just 1 second, Daddy's almost done. We're making sure the workforce is diverse, but we're also making sure the leadership is diverse, and we're doing as much as possible to promote from within to be able to accomplish that. And what we mean by a equity-focused organization should be one that, of course, recruits from the community. One of the biggest contributors to Hire Newark initiative that Mayor Baraka has in the city. But then we cultivate, we grow, and we make sure that we invest in our workforce so that they can go up the ranks and end up leading this hospital at one point. And so that's a major thing we're doing. We're also altering our procurement strategy to make sure that local and businesses that are owned by people of color, women and minority-owned businesses and veteran-owned businesses are prioritized. And that is a process whereby we are working with the Newark Anchor Collaborative and the Newark Alliance to be able to accomplish that. And we've been much more active participants in those organizations since I've gotten to the hospital. And then finally, we are really working toward a population health strategy that involves really solving problems for people and not sending that homeless person back on the streets after we treat their pneumonia, only for that person to come back in with the same problem later. And that will require investments over a long period of time, changes in policy, demanding our seat at the table for resources and equity in the distribution of those resources. And we're doing all those things for the benefit of the community. Thank you again, and I apologize for my son.
No apologies for, children, working parents during the pandemic. This is, that's your colleague that just joined you, and it's probably around bedtime, and they just want to say, hi, Daddy, and good night. There's a three-part question for me. From a health perspective, do you think it's a good idea for the United States to have some type of vaccine ID to help identify, track, isolate, and control the spread of COVID-19, as some countries in Europe are going to try to implement what are the pros and cons in trying to establish a vaccine ID system? I mean, I think from just the very peripheral ease of travel, being able to show that you've had your vaccine and that maybe in your destination, it makes a difference in terms of whether you need to quarantine, so forth and so on, that's going to be helpful. Question number 2, do you think that the 1-dose Johnson & Johnson vaccine is better for certain Americans to receive compared to the 2-dose, depending on their level of risk exposure to others related to their field of work? I will say that for the rapid mobile response team that I've built at the Department of Health, it's not so much of certain Americans and their risk exposure, but it is about place, right? And so when my vaccine mobiles go out to a soup kitchen, to a homeless shelter, knowing that that could be a very transient population and that we may not be able to find them again for a second dose, I think that for those circumstances, that being able to give them a 1-dose regimen that's going to give them some immunity becomes important. And the third question in that series is, according to last week's news, New Jersey has the highest positivity rate of COVID-19 infections. I would assume this is attributed to the highly densely populated areas. New Jersey is the most dense state. If the COVID-19 infections doesn't decrease at the rate needed, do you foresee in the future a mandatory vaccine shot in the state of New Jersey? We know that Rutgers is making the vaccine shot mandatory for its students and faculty. Dr. Elnahal, Dr. Davis, what do you think about mandatory COVID shots in the state of New Jersey?
No.
I don't think so. No. Did you go? You go first, Dr. Elnahal.
People need to be there in wanting to take the vaccine. I firmly believe that. We need to reach herd immunity to get out of this pandemic. That'll be dependent on what folks want to do ultimately. But to force an intervention, especially vaccines that are under emergency use authorization and not full approval from the FDA, I think would be unethical. And all it would do is frankly create resentment and breed even more distrust in the very communities that we're trying to reverse that trend in.
Okay. I'm looking at
lots of amens.
Yes.
I mean, I gave them all those. That was a traditional.
Caveat though, sorry, Dr.
But you say that.
I will say that will it likely be something that you would need to verify to go into a live performance or a movie theater or a bar at some point? That will be up to the proprietors of those businesses, who will want to be able to attract as many people as possible again. And so that may be something that comes up in different aspects of your life where you don't expect it. I don't want to make it sound like that's not going to be something you have to face.
I think it's a slippery slope though. I think it's a slippery slope because one, there's not adequate access in this country for everyone to get a vaccination that does want one. Because I mean, if you can't even figure out how to open up your slots for anyone that they're not on broadband and don't have a car, then obviously you're not talking to most of the poor or urban populations in this country. So let's get really started on, okay, this is how you go down the slippery slope. Then when you start dealing with a number of anti-vaxxers, as you pointed, was it you or was one of you that pointed out that the greatest anti-vaxxer community in our country right now is actually of Euro-American descent. And it is primarily of what would be considered a conservative political group. But there are anti-vaxxer groups I have found in all the societies. As someone who works in internal medicine and functional medicine, I see a lot of people say, well, I'm just going to keep up everything, measure my antioxidants, da, 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 da. And I'm like, well, now, wait a minute. You know, a virus may not be as active in you, but you're talking about a lethal virus here. And I can't predict your capacity, and I don't know your area of prevalence. And so when you start having to teach those kind of words to people, prevalence means how widespread is the virus in the community that you live in, work in, and walk in. You know, so I think that, so when you start talking about the kind of thing that you're discussing, I feel like, oh, okay, we're gonna, 1 out of 5 people that are African-American can stay home and work. I'm like, oh, must be another Google person that's like, I got this. That's exactly how I feel. I feel like that's a class-based racially based structural issue. Back off.
Okay. And so on that note, I thank the panelists for, joining this evening. This has been a very lively and useful discussion. I am going to turn it back over to Donna to close us out.
Well, my goodness, this was absolutely amazing, as we knew it would be, with having such stellar professionals and passionate physicians. Thank you so much. Thank you for our audience for your thoughtful questions and for your vigilant attention. Please join us tomorrow. We're going to have a conversation with Savion Glover. On Wednesday, we'll be saluting our Asian American Pacific Heritage Month with our Wellness Wednesdays. On Thursdays, we're going to have Jersey Fresh, highlighting some of New Jersey's hottest new talent. So every day, there's something at NJPAC that's going to help inform your life. And we look forward to seeing you in the future. Thank PSE&G for your continuous sponsorship, and everyone have a great night, and let's be safe and smart. Thank you.